In this video, I'll show you how I read an MRI of the cervical spine. So there's a lot of different ways to do this. These are just a couple suggestions. So first off, the text give us some scout images. So there's a big field of view. I just look really um, quickly at this, make sure that I'm not missing like a huge mass somewhere on the corner shots, right? Any big lung mass or anything like that. Any mass in the shoulders that you might miss. Any mass in the soft tissues you might otherwise miss. And sometimes the scout images go all the way to the thoracic spine. Make sure I don't miss a thoracic spine mass. Okay, so now I go over to the T2, and what I usually like to do is I like to label the vertebral bodies. I don't always do this, especially if it's a normal looking exam like this. I don't always label the vertebral bodies, or if it's a trauma study, I don't normally label it. But if they're doing it for some kind of radiculopathy, degenerative change, then it's nice to label it so that you can actually remember which level is which when you assess the spine level by level. Okay, so now everything's nice and labeled. I first start out by looking at the stir over here. This is one of my favorite sequences, especially in the setting of trauma. Okay, so what I do is I start centrally and superiorly, and I work my way down, and I work my way out. Okay, so first off, I look at what I can see of the brain. Sometimes you can see a Chiari malformation, so you don't want to miss that. Look at the cerebellum. I look at the brainstem, look at the pons. Sometimes you can see these chronic pontine infarcts or chronic white matter change in the pons. Okay, and then now I just kind of look both sides, right? I look at the cerebellum on both sides. Sometimes you can see these little cerebellar infarcts. You don't want to miss that. And then I look at the both sides of the brainstem. Okay. Take a quick look at the cerebral pontine angles. Make sure you don't miss a mass there. And then I always look at the pituitary gland, the sella. Make sure I don't miss a mass in this region here, in the cellular supracellular region. And finally, I see what I can of the brain parenchyma. I can see part of the temporal lobes on both sides and the occipital lobes on both sides. Make sure I don't miss like an infarct or any kind of mass. Okay, now I look centrally at the spinal canal, and especially of the cord. So over here, this is the normal central canal of the spine. Here's the obex, and I look for any cord signal abnormality. The stir sequence is very sensitive for any kind of cord signal abnormality, but sometimes it's not very specific. You get some artifact. So if you think you see something, try to verify it on the T2 and also on the axials. So look at the cord. Just make sure there's no cord signal abnormality. And then now I look at the thecal sac, right? The thecal sac should follow CSF on all sequences. So I look at the anterior CSF column, the posterior CSF column, and sometimes you can see this little line here, right? This line on this side, and a line posteriorly. And that's just the flow voids. So make sure the CSF is the right signal, nice and bright on the stir. Okay? And now I look at the cranial-cervical junction. Okay, I look for any kind of edema at the cranial-cervical junction. It's normal to get some edema in the Bayesian dental interval, or not edema, but basically bright signal. And that's just, I don't know, anatomically, that's just the way it is sometimes. It's not edema, it's just some bright signal on stir. At the Bayesian dental interval, that could be normal. I look at both sides, make sure I don't see any edema along the lateral and the anteroaxial joints. Okay, great. And then I look at C1, make sure there's no bone marrow edema. I look at C2, look for any kind of bone marrow edema. I look at the posterior arch, the spinous process, the dens for any edema. And then I look at all the vertebral bodies, and I look for any kind of vertebral body edema. Okay, which can indicate a fracture. Okay, great. Now I look at the spinous processes, make sure that they're intact, make sure there's no abnormal edema. Okay, and then after that, I look at all the facet joints, look for any kind of facet joint edema. Most commonly, it's associated with a degenerative change. But every once in a while, you can get septic arthritis of a facet joint, or you can get some capsular injury. So you look carefully at the facet joints, make sure there's no abnormal edema. Okay, and now look at the ligaments. See, these are the interspinous ligaments here, and the ligamentum nuchae. So look for any kind of edema on the interspinous ligaments, which can mean a ligamentous sprain. Okay, and now I look at the paraspinal musculature. It's not uncommon to see a muscular strain, which would be bright on the sequence in the setting of trauma. So I look at the paraspinal musculature on each side, okay, for any kind of edema. Great. And then very importantly, I look for prevertebral edema, okay, which can be seen in the setting of anterior longitudinal ligament injury. Sometimes if you have life support tubes like a ET tube, it can cause some reactive retropharyngeal edema. So that can kind of be a little confusing, but normally there shouldn't be any prevertebral edema here. Okay, great. All right, and then so after that, I pretty much, this is a great sequence for looking for, masses, looking for ligamentous injury, and looking for edema. Then now I take a look at the T2s. Okay, I look one more time really quickly at the brain. Usually I'd catch, most of the things I'm looking for on the stir, but it doesn't hurt to take a second look. And I look at the spinal cord, looking for any kind of signal abnormality. And then I look at the thecal sac. I look for any kind of signal abnormality. It should be nice and bright on T2. I can see some flow voids here, which are normal. Okay. And after that, I look at the alignment and the vertebral body heights. So make sure that there's no subluxation. Look at the anterior the anterior spinal line, posterior spinal line, okay, spinal laminar line. Make sure everything's nice and aligned. I look at the vertebral body heights, make sure they're all intact. I look at the disc heights, and I comment whether or not there's any disc height loss. Okay. Look at the Bayesian dental interval, atlantal dental interval. Make sure alignment is okay. All right, and then after that, I clear all the ligaments, especially in the setting of trauma. So you want to clear the anterior longitudinal ligament, and the continuation of the anterior longitudinal ligament is the anterior atlantoaxial and atlanto-occipital membranes. So here it is. Make sure that's intact. Okay, and then I look at the posterior longitudinal ligament. Make sure that's intact. The continuation of that is the tectoral membrane, so make sure that's also intact. And then I look at the ligamentum flavum. See that? Here, sometimes it's a little hard to see, but this ligament here should be intact. The continuation of the ligamentum flavum is the posterior atlantal axial and atlanto-occipital membranes. Make sure that's intact. Okay, the ligaments look intact. All right, and so since I'm already at the ligaments, sometimes I like to skip ahead and I basically clear the transverse ligament of the dens, which is located right over here. See that? Here is the dens, and the transverse ligament of the dens is this ligament right over here. It's supposedly the strongest ligament in the body. It's very important for stability of the craniocervical junction and the cervical spine, and it basically attaches to the lateral masses of C2 and wraps around the dens. So make sure that's intact. Here it is. Okay, so I'm finished with my T2 sagittal. Now I go to my T1 sagittal. Okay, this over here, I look for, basically I look at the CSF signal. CSF signal should be really dark, and that looks normal. Because sometimes you can have an epidural hematoma, and the epidural hematoma can sometimes look bright on the T2 and the T2 stir, and it can just look just like CSF, like a subdural or epidural hematoma. It can look like CSF on the T2, but it's bright on the T1, and so that might be the best sequence where you can catch an epidural or subdural hematoma in the spine. Okay, and then I look at the cords, basically the vertebral body bone marrow signal. So on the T1 images, the T1 bone marrow should be brighter than that of normal disc. See that? It's T1 bone marrow is brighter than disc. And also another reference is that it should be brighter than the surrounding skeletal muscle. See, the skeletal muscle is dark. The bone marrow is nice and bright on T1, so that looks normal. And then sometimes I can see alignment a little better here on the T1 images. Okay. Now let's go to the next set of sequences here. Okay, so here I have some axial images. I have a T2 axial, I have a GRE, I have a T1, and have a T1 fat sat, which you get when you get cervical spines with and without contrast. So let's start with the T2. So basically I look at the cerebral hemispheres, look for any infarct, and I look at the cord. So I start centrally and I go peripherally. I look at the cord, make sure there's no cord signal abnormality. I go down, I clear the cord, okay? And then I I look at the arteries. So I should always see the vertebral artery flow void. See that over here? Sometimes it can go missing if it's occluded or dissected, so you don't want to miss that. Look at the vertebral artery flow void here. And you can see the carotid artery flow voids too. That should also be present. Okay, and I read the rest kind of like I read a soft tissue neck CT. If I can see lung apices, I look at the lung apices. I take another look for prevertebral edema here, which can be an indication of anterior longitudinal ligament injury. And I know there's a saturation band, but you want to make sure you don't miss any kind of mass along the aerodigestive pathway. Okay, sometimes you can see like a thyroid nodule or mass. Look at the parotid glands, make sure I don't miss a parotid mass, some mandibular glands. Okay, and I look for any kind of incidental lymphadenopathy. Okay, now in the setting of trauma, I actually take a look at the scalene muscles, right? You have the anterior, middle, and posterior scalene muscles. I take a look at that because sometimes they can be strained. So look for any kind of edema. And also importantly, you can look along the course of the brachial plexus. It travels along the subclavian artery between the anterior and middle scalene arteries, and you want to make sure that there's no, soft tissue swelling or edema along the brachial plexus. Here's the brachial plexus on the other side, and you especially want to do that in the setting of trauma. And I look at the paraspinal soft tissues posteriorly. And so basically I'm reading it kind of like a CT soft tissue neck. And here's the GRE. I take a look for cord signal abnormality. This is, in the setting of trauma, this is good for looking at like a hemorrhagic cord contusion. It would look like a black focus of hemorrhage in the cord. Okay, great. And I take a quick look at the soft tissues, look for any kind of abnormal edema. All right, T1, I go down, I look at the, basically the CSF signal should be more or less pretty dark. You can also take a look at the flow voids on T1, if you'd like. And take a quick look at the soft tissues, but not too much to do with the T1. T1 fat sat, I just take a quick scroll through. If I don't see anything on the T1 without fat sat, I probably won't see anything here. This is mostly for the post-contrast sequences. Now, next couple of sequences. So here are the post-contrast sequences. This is the T1 fat sat axial post-contrast. This over here is the sagittal T1 fat sat or T1 post-contrast. Now, the way that we do fat saturation for the sagittals is that we get post-contrast images out of phase, which you see here, all this India ink artifact, and we get post-contrast images in phase, which is what we see here. And we use these two images to create our fat saturation post-contrast images here. And so I look at it like the other sagittal sequences, where I look at the brain, make sure there's no abnormal enhancing mass, cerebellar pointing angles. I look at the pituitary gland, see that's nice and enhancing. I don't see any abnormal cellular or paracellular mass. Okay, I look at the cord, make sure there's no abnormal cord enhancement. Look carefully, in the setting of multiple sclerosis, make sure you don't have any enhancing cord lesions. Then I look at the vertebral bodies. I look for any kind of a vertebral body enhancement. Okay, look at each vertebral body, look at the spinous processes, look at the facet joints, make sure there's no abnormal enhancement. And finally, I look at the interspinous ligaments and the paraspinal soft tissues. Look for any kind of, myositis. Okay, and I look at prevertebral soft tissues, make sure I don't miss anything, any normal enhancement. Okay, and then for these sequences here, the out of phase and in phase, sometimes you can just ignore them because the point of these two sequences here is to make the sequence up here. Um, but sometimes if you have a questionable finding on the post-contrast images, you can look at the out of phase images to see and verify if that thing that you're seeing is enhancing. And sometimes you can see enhancement a little bit better on the out of phase images here. In phase images, it's hard to see enhancement because there's no fat saturation. And finally, last but not least, they give you subtraction images. This is post-contrast subtraction images, axial. And I quickly scroll through, make sure there's no abnormal enhancement. Usually, if there was anything abnormal, I would have already caught it on my axial post-contrast here. And yeah, I think I forgot to mention about what I look for in this axial post-contrast, but look for enhancement in the cord here. And I look at the soft tissues, right? Longus colli muscles, right? Thyroid gland, parotid glands, soft tissues here. Look for any kind of abnormal enhancement. Yep, and then after that, again, usually I look at forgot to mention it, but I forgot to usually look at these axials post-contrast first, and then I look at the subtraction. But either way, it's totally fine. And that's and so if this is the setting of like looking for a mass or looking at a trauma, sometimes this is where I would stop if the cervical spine looks otherwise normal. But if there's degenerative change or if they're looking for radiculopathy, then I go level by level. So let me show you what I mean by that. So basically I have axial T2, GRE up here, and then I bring up the T2. You can also bring up the stir if you'd like. And basically what I do is I look at each and every level and I describe whether or not there's spinal canal or neuroforaminal stenosis. So let me get this reference line here. Perfect. And then I have these crosshairs too that I can use. All right, so I go look at each and every level. I look for spinal canal and I look for neuroforaminal stenosis. So here, level C1, usually there's not too much going on there. Sometimes you can have degenerative changes of the median dental axial joint and some retrodental soft tissue thickening. And so you can mention that if it is there. And let's start going our way down. So basically, I look at my T2 axial and I kind of correlate with my T2 sagittal. And I work my way down. Over here, this is the level of C2, C3. This is why it's nice to have labeling. There's no spinal canal stenosis on either images, and there's no neuroforaminal stenosis. It looks widely patent. Then I look at C3, C4. No significant spinal canal stenosis, no neuroforaminal stenosis. C4, C5, spinal canal is good. Neuroforamen looks fine. Sometimes these flow voids can be tricky, and so you can look at the GRE to verify that there's no spinal canal and there's no neuroforaminal stenosis. Okay, so these are both complementary, right? The GRE can have artifacts sometimes, the T2 can have artifacts sometimes, so you can look at both to make sure that the spinal canal is patent and that the neuroforamen are patent. And work my way down here. At C5, C6, spinal canal is patent, neuroforamen are widely patent. Work my way down, C6, C7, spinal canal is patent, neuroforamen are widely patent. Work my way down, C7, T1, spinal canal is patent, and the neuroforamen are widely patent. And that's how I go level by level. And again, I do this when there's an abnormality, like a posterior disc osteophyte complex, or if they're looking for any kind of radiculopathy or a myelopathy or degenerative change. And that's how I read an MRI of the cervical spine, or with and without contrast.